wonder how many diabetic patients I saw today. And you looked at your schedule and you saw 7 diabetic patients that day, which may not be that unusual for a primary care practice. And you just happened to ask your question, you know, I wonder with those 7 patients I saw today, how many of those 7 patients did I actually achieve or get a hemoglobin A1C on? And you may look back at those 7 and pull those 7 charts and look and find out, well, I did get a hemoglobin A1C on 6 of those, but for some reason on the 7th one, I haven't had one in the last 3 months. So in that little question, you set an aim. Ideally, I want to get 100% of my 7 patients having hemoglobin A1C. You used a metric, hemoglobin A1C. You did an analysis of your performance, 6 out of 7. That, in a nutshell, is sort of what we're asking us to begin with. But then let's say you were concerned as a conscientious primary care provider that you only got 6 out of 7, so you had time, you asked this question, well, I wonder if I pulled 100 of my patient's chart, how well am I doing with my patients? And you reviewed 100 charts. Let's say you don't have an EHR, manually reviewed that and found out that you counted all 100 of those diabetic patients, and 70% of the time you got a hemoglobin A1C in 3 months. Now, if you were a conscientious primary care provider, you would say, that's not very good. I'm not satisfied with 70% of my patients getting a hemoglobin A1C in 3 months. So you talk to your nurse and you say, we've got to do better with this. Listen, I tell you what, why don't you, when we have a diabetic patient coming in, why don't you look through the chart and let me know if I've gotten a hemoglobin A1C in the last 3 months. So we've taken, let's put this in the language of performance improvement. You've taken a population of patients, 100 patients. You've evaluated your performance, 70%. You're not satisfied with that result. So you set an aim. I want to do better. I'd like to get to 100%. You talked to your nurse and you created an intervention. That intervention was the nurse helping you review the chart and the data, and the intervention was help me know that I haven't got that so I can order the test. And so let's say you did that, and then 3 months later, you went back to those same 100 charts, or you pulled another 100 charts and you did the same evaluation and found out that this time, 85% of the time, 85 out of 100, you acquired that hemoglobin A1C. So you set an aim, you measured, you put in an intervention, you followed it for 3 months, you went back and evaluated and saw that you'd improved on that measure, on that population of your patients. It's not complicated. It wasn't difficult. That's, in a nutshell, what we're talking about, using data to affect change. Pretty simple stuff. So as we go through some of the concepts, I'm going to try to touch base to that simple story about a provider who's trying to improve the care of their patients in their clinic using data to affect change. So this is what we're going to go through, hopefully what we can accomplish by the time the presentation is over. And I'm going to begin with a slide on MACRA, MIPS, and APM. So MACRA is the legislation, MIPS is the payment model that almost all of us are going to end up in. I'm going to start down here on the bottom row. This is the time frame. So we talked a little bit about PQRS measures right now. These are going to go away, and they're going to be folded into a different measurement system that includes these 4 elements. 50% of the score, this comprehensive score that's created by MIPS, is going to be on quality measures. 25% is going to be on advancing care, 15% is going to be on clinical practice improvement, and 10% will be on cost. That's what it looks like the first year, which the payment model for Medicare MIPS begins in 2019, but the critical thing to understand is the measurement period for how you're going to get paid in 2019 begins January 1st of 2017, so less than 7 months away. And what we heard this morning is how we'll get paid in the MIPS program, this plus minus 4, plus minus 5, plus minus 7, plus minus 9 over those 4 years. It's a zero-sum game. That means that there's going to be, all the providers are going to be put into a rank score and put into quartiles. Top quartile performers will receive the bonus. The bottom quartile performers will receive the penalty. And that penalty and bonus increases as the years go by. And all of this is driven by data, cost data, and particularly quality data. Now, the good news is, we think, that the quality metrics, there will be a portfolio, a universe of metrics to choose from, and the practices will get to select 6 of those, which they'll hold themselves accountable to. The other good news, I think we just learned here recently, is that those that are participating in TCPI will get 100% credit for the clinical practice improvement work. Is that right, Mike?
They're at least heavily weighted.
Heavily weighted. So we have a leg up for this piece right here. So when we talk about data and quality data and thinking in the future, these measures and understanding what those measures are and reacting to them are going to be important. This is the 5-phase transformation that we talked about this morning. We'll be talking about using data to drive care, and this is all a data-driven process as we work through these 5 levels. And you, as you begin, will become more and more sophisticated all along the road to achieving this place at stage 5, ready for a value-based world. I think this is the meat of the presentation. Some key things, and Vineeth is going to share 5 elements as well. I don't think there's, typically we look at data and as clinicians will say it's bad data. I don't think there's really, quote, bad data. Data is, it has weaknesses and has strengths. And understanding the source of the data, the scope of the data, and the purpose of the data is a really important reference point when you think about how you're going to use this data in your clinic. So typically in healthcare, when we talk about sources, there are claims data. This is data that is generated from a clinic visit through the billing process, to the coding process, to the payers, and then generated afterwards. It's a multi-step process. And there are limitations to that claims data. It oftentimes is delayed several months, sometimes can be up to 6 months before you get that information. Anytime that a data stream has been touched by multiple steps along the way, that information gets shaped and reshaped. So by the time you see the results of that claims data, it may or may not reflect the actual clinical care. The variation that you see in the data may very well reflect the process variation of collecting the data. And that's a really important understanding. And the early part of your work in improving your care through using data, oftentimes the first place that you begin to make improvement is on the piece about this data stream, the integrity of that data stream, how it's collected, how it's reported, and generated. You can make improvements in that piece of the work, and sometimes clinicians get frustrated with that and think, well, this doesn't have anything to do with really what care is. And I have responded saying, our future world requires that we are not only clinically astute, and that we do that well, and that's important. But we also have to be astute about how we're graded. We have to understand how we're graded, where this data comes from, and figure out ways to improve and make sure that we're getting full credit for all the work that we're doing. So that's some comments about claims data. There's data from the EHR, or if you're still on paper, from the paper record. But from the EHR, its strength tends to be that you can get that stuff right away. It's just pulled out of the EHR. There's no delay. And oftentimes, when you think about how you're going to use that, people really are thirsty for the EHR data. One of the limitations, however, is that the only data you see is the data that has occurred in your system, in your EHR. And you know, and I know, that the real world, patients get care outside of your system, outside of your community. And you will be blind to that information because it's not in your EHR. So that's one of the limitations of electronic health record data. When you look at it and you think about the report, you have to keep in mind, what's the source and where it's coming from. Of course, we can do patient surveys. That's where we're going to get most of our experience scores, which no doubt will be included in how we're measured. The second piece I want to drop down to the bottom is the purpose, and I think this is really important as well, in that what are we going to be using the data for? Why the data is being measured? Most of us are very familiar with this comparative reporting. What Tom said this morning, the scatter plot stuff. For those that are out in the hospital world, it's the core measures for CMS. It's the regulatory reporting stuff. It's the stuff that you see sitting around the table in the C-suite as you want to know how your organization is performing. Performance data, comparative reporting, and that's valuable information. It tends to be retrospective. How did we do in the past? It can guide you. It can be directional. It can raise important questions. But the one thing that I will say that it's not particularly good for is it's not very good for performance improvement. Performance improvement data needs to be as close to real time as it can be, because you're going to put interventions in place that you hope change the results, and you're going to know very quickly whether or not that intervention has made a difference or not. You don't want to wait. It's very difficult to do performance improvement when you don't see the results in the data for 6 months. It's too much of a delay. And so the sources that we tend to use for performance improvement or prefer, if you listen to this first part, is you can see that the EHR might be the preferred source for performance improvement because it's more timely and it's more direct, and there's not very many steps between getting that data and using the data. And then likewise, the claims data, which tends to be retrospective, we do like the EHR data, may be more appropriate for comparative reporting, but it has limitations as well. So source, scope, and purpose, always important to keep that reference point. And when you're working with your clinicians, to shape their thinking about this as well, understanding the data all has limitations, that there isn't a perfect source of data. And we just have to look at the information that it's telling us through the lens of the source and the purpose of the data that we're given. The other thing that I will say, too, about data is that as clinicians, we tend to think the data has to be pristine. What we're used to is descriptive statistics, double-blind, placebo-controlled trials, and the data is pristine. Performance improvement data does not have to rise to that standard. It just has to be good enough to tell us a reasonably accurate portrayal of where our opportunities lie to drive improvement. And as long as the way we measure it is consistent, we can understand that direction, put an intervention in place, and then follow the improvement over time and say we've gone from A to B, and the delta, the difference between where we began and where we ended up, is what matters to us. Not necessarily whether or not that number is actually pristine perfect, see? So it just has to be good enough data. We're not writing research papers. And that's sometimes a helpful reference for clinicians. We think about data strength. This slide was to try to underpin the story that I told you. So let's go back to the story. You're the clinician, you're pulling information, and maybe with this reference point, you can help me think through what was the source in that clinical story. What was the source, closest source here for that data? You have 3 choices, so which one do you think it was? The EHR. So what do we know about the source, about the EHR? I told you what the strengths were in that case. It was fast, accurate, right? And in our story, we used paper-based. Okay. So what was the purpose for the data of those two? Performance improvement. Now, here's the tricky one: outcome measure or process measure. Outcome measures, I believe, are in the eye of the beholder. What are we hoping to achieve at the end of the day? Is a hemoglobin A1C an outcome measure? How many people think hemoglobin A1C is an outcome versus a process? Is it a measure of process? Something along the way towards an ultimate end, something that would tell us we're making progress towards what we want to achieve, but it's not what we're striving to achieve. So how many people think that hemoglobin A1C is an outcome measure? We'll do an outcome measure. I saw a couple of hands. How many believe that hemoglobin A1C is a process measure? I believe you. I believe it's a process measure. So that's our story. Using the clinical and those guidelines, we took the individual patient, that doctor who looked at 6 or 7 of their patients, looked at the diagnosis, collected this data, and how we've translated that day-to-day routine thing that we all do every day and looked at it through the lens of a population. In our case, it was 100 patients. But maybe that clinician says to his peers sitting around a cup of coffee, I really, as Tom says, it's good today to, what did he say? It's good to suck. So I really suck. 70% of the time is all the better I did. And the docs got to talking and said, I wonder how good I'm doing. And pretty soon there's 3 or 4 of them that's saying, I think we should look at all of our diabetic patients. All the docs got on the table and now your population is bigger. Now it's the whole clinic. And you can actually look at that population through the system. Or you can look at that population across the region. So, but it's all anchored to that beginning point. One patient, one doctor, one set of data, and all we've done is we've just broadened the scope and tried to understand how well are we managing this group, whatever that group is that you're defining. So here's an example. This is actual data. I'm going to tell you what the source is. This is the employee health plan data from 9 founding members of Enhance. Represents 45,000 covered lives of employees. And this is claims data. So what do you know about claims data? We talked about it as a source. What were some of the limitations? Slow. Can you think of another limitation potentially of claims data? What's that? I heard something. Shout it out. Incomplete. It is incomplete. It can be incomplete. One of these that stands out is a colorectal cancer screening, right? What do you ask yourself? Okay, it's claims data, it's delayed, it's potentially incomplete. Do you believe 31%? Ruth is saying, no, I don't believe it. Why, Ruth? Why don't you believe that? Right, so the way we measure colorectal cancer screening is this 10-year period, and you begin to ask your question, can we actually get good information from claims data about colorectal cancer screening? That means that it's always been coded correctly for the screening process. There are multiple ways to screen, and it does raise questions to say, well, I don't know if that's real or not. But the point of showing this slide, the population, 45,000 people, employees, claims data, looking at the information through the lens of the weakness of the data, and you may say at your organization, I wonder if we've got another way to look at this to make certain that our employees are not missing out on getting colorectal cancer screening, because if that's a real number, that would be concerning. Concerning from an employer standpoint, wanting your patients to be healthy, concerning from a provider standpoint, that we certainly want to do better than 31%. If you looked at the state average, I think that's about 20% below the state average for adult screening and colorectal cancer screening. So a lot of questions that you could test you're thinking about, look at other sources of information in your organization to see whether or not it's true. So I just showed this to go back to the source, purpose, and looking at data through the lens of the limitations, and it's not really that it's bad data or it's wrong data, it's just claims data, and we have to understand what the story is that's telling us. So when we talk about the Transforming Clinical Practice Initiative, one of the main things is for us to help you acquire data and then to do something with the data. And when we say do something for the data, what we mean is, how can we assist the practices to do just what that physician at the beginning when I told the story could do? Basically, that physician used a plan, do, study, act improvement cycle. Did an analysis, so looked at the data, created an intervention, put that intervention in place for 3 months, went back and studied that, and then we'll move on to the next cycle. So we use this very, very simple process improvement methodology within the clinics, and we assist the practices to do just what we talked about. We'll use the PDSA cycle. The quality and improvement advisors are there to support the practices and how to extract the data, use the data, look at the data to create the plans and development. And then we support that with the community as we have learned from each other about how well that's going. So that is the basic engine that we're going to use and how we're going to interact with the data. So how do we collect it for the practice groups? We're working with our partner, Telligin. Telligin is using a tool called QualTrack. And our plans at this point are that the data will be collected and reported through that QualTrack tool. That there are multiple ways that we can collect this, directly from the EHR, a manual entry, or a combination of those two, depending on what your capabilities are in your clinic. Then the reporting for that data is going to be done through a web portal, and my understanding is that getting down to individual patient level reporting is an optional for the group. So Telligin provides the tool. They will be working on the tracking and the reporting. There'll be support for using the tool as well. So that is for the TCPI grant, our engine, the Compass PTN, for collecting the data, analyzing the data, generating reports back to the practices, and all of that facilitated by the QIAs and their assistance with the practices. So once we have the data, then again using the QIAs, we will use this PDSA cycle and put a small intervention in place, track that for a period of time. As you continue to collect your data on a month-to-month basis, that report will be analyzed and will be provided back to the practices, and that's where the QIAs will have conversation with the practices about, how could we move on to the next step, what did we learn from that, and then we start the cycle again. These are the measures. There was considerable work went into the process of selecting these, and these, I'm sure, are not a static list. We know that there needs to be specialty metrics as well, but this is where we're beginning for performance measures, and you can see that there are references, what the definitions are. Many of these you should be familiar with, and this is intentional. When we were thinking about what measures we would put in the grant, we went out and got every single required measurement reporting list that we could find or think about. We put them on a spreadsheet. We said, all right, which ones are included almost all of those. We narrowed that scope down and tried to come up with measures that almost everybody we thought were already reporting or were familiar with, and I think you can see that list. We've broken these out by outcome measures and process measures, and you can see that number one on the outcome measures, which we all just voted on, was that it's an outcome. And I had this conversation with Vineeth before. I said, I don't think that's an outcome measure. That's not what I would say an outcome measure. As I said, it's sort of in the eye of the beholder, I guess, what an outcome measure is or not. I think outcome measures are outcomes that matter to patients, not necessarily outcomes that matter to us. I would consider that to be a process measure. But nonetheless, that's how we've clumped these together, and you have that list that you can look at. So we talked about how did we select these. We started with, what's out there with the national standards. We wanted to link, and we asked the question, what are we getting paid for already? So we're not creating something new. We try to put those measures, be aware of those measures. We're exquisitely sensitive to a reporting burden that all of us are already living in, and we certainly didn't want to be in a place of adding to that reporting burden. We wanted to keep the measures simple, and that was part of using metrics that already had been defined, and we wanted to make certain that we could actually move the ball on those metrics. So I don't think there's anything remarkable or new about those measures, and I think it goes to the bottom statement. If there's a takeaway message I'd like you to walk away with about TCPI, and it's very easy to get stuck in this trap. The work we're doing is not about the data. The work we're doing is about the improvement, the culture, the team, the work of how we go about the care we deliver. The metrics are like a thermometer that tell us whether or not we're ill. We don't treat temperature, we want to know what the cause of the illness is. And in some ways, data is the same way. Data is like a thermometer. How well are you performing? Are you ill or not? And then you intervene where the disease exists, if you will. That's where your intervention takes place. So having the data is not the same as using the data. And I think sometimes in healthcare we get stuck on having and reporting the data. So using it through performance improvement is what we're trying to accomplish. Now, I am going to transition over to Vineeth here, and we've got a series of slides that show performance data from Enhance. And I want to make certain you understand why we're showing you this data and why we're not. We're showing you the data because we don't have access to TCPI data yet, and we want to use it to just underscore the source, use, and process and what things look like from a network level. What I don't want you to do is I don't want you to look at this and say, oh, Dr. Hein is expecting us to go back to our clinics and improve these metrics I'm showing you. That's not what the intent of this. In fact, I think for some it would be very difficult to translate your day-to-day work with some of the data that we're showing here. So it's illustrative only. It's try to link us back to some of the key concepts and lessons learned about using data that Vineeth will underscore. So with that, I'm going to turn you over to Vineeth.
Thank you, Dr. Hein. Can you hear me okay? Okay. So I usually tend to speak faster, so I'm going to try to speak slower this time. So keep me honest here. So one of the things that we have done at Enhance in the last couple of months is an annual opportunity analysis. So here we took the data that we have available, and with the limited data sources that we have, we analyzed this information and created this 200-page plus report of opportunity analysis. So this is where we identified all the different opportunities that we have access to the data. So basically the intent of these slides that I'm going to show you is just to demonstrate why we are using and what is the purpose of the opportunity analysis and how you can use some of these things in your clinics or in your organizations. So some of the data sources that we have access to right now is the county health rankings and the state health rankings. And as Dr. Hein was talking about, the Crimson population risk management, which utilizes the claims-based data. So we do have access to that information, and obviously the CMS Medicare data. So let's jump on to the next section, which is the county health rankings. If you've looked at our Enhance website or know about Enhance, our mission is to enhance health. So how do we improve health if we don't know how we are performing and where we have the biggest opportunities? So that's the reason why we use the county health rankings to see how we are performing and where we have the biggest opportunities. So Nebraska is ranked number 10 in the country. And so it's very important for us to look at the different factors that affect the county health rankings and then identify how we can progress on that. So this is the county health rankings model. If you look at this, so you have the policies and programs that impact the health factors, and the health factors impact the health outcomes. The health factors is broken down into physical environment, social and economic factors, clinical care, and health behaviors. So if you look at this really close, what we do in healthcare, we can only impact 20% of health. So it is very important for us to partner with other bodies in the community to make an impact on overall health. So what we did at Enhance was, so we looked at the data that we have by county, and we identified, our market share with our 9 member organizations, and identified, how we are performing. And we have calculated the Z-scores for Enhance overall for health outcomes and health factors. So you can see this Z-score. So the Z-score is the standard deviation from Nebraska mean. So 0 is the standard deviation, is the Nebraska mean here. And if we are performing negative, then that means we are performing really well. If the Z-score is positive, then we are performing poorly compared to the state. So in here, for health outcomes, for 2015, we are performing at minus 0.03 Z-score, and we have improved to minus 0.1. So we have made a huge progress in health outcomes as Enhanced as a whole. And health factors from 2015 to 2016, we almost stayed the same. And again, here we did break down the different measures under health outcomes and health factors. So you can see the length of life and quality of life. So we did make some progress here for length of life and huge progress in quality of life. But still, we are above the state average here. So we do have opportunities in here. And if you look at the health factors, so clinical care is one of the domains where we are performing really, really well. But social and economic factors is one of the domains where we have huge opportunities in terms of health factors. So for us to really impact health, we need to identify, what are the reasons why, why we are performing above the state average, and what can we do in order to improve those things. So this is just an example of, looking at data as a whole at a, state level or a county level, and see, what are the factors that are influencing in, and how can we actually impact those different factors. So the next subsection is around the Crimson population risk management application that we use to measure our employee health population. So we have nearly 46,000 covered lives, and it's claims-based data. And we have done a detailed analysis on this, and I'm going to show you a quick snapshot of the information that we have in there. So this is another key initiative that we are working as Enhance. So the generic drug utilization from 2013 to 14, we have made huge progress, and you can see how we are performing in 2015. So this is incremental progress that we are making, and this is one of the key initiatives, again, we are focusing at Enhance. So this is another example of a utilization metric. You can look at the number of MRI scans done per 1,000, and if you compare our performance with benchmark, there's huge opportunity. So it is important for us to go back and look at the data and see, is there a true opportunity in here, or is the data saying something different? So it's very important for us to do the analysis with some other sources of information locally. So here's another measure around diabetes, which presents opportunities around cost. So this is the PMPM, the per member per month, and you can see how we are performing in 2013, 2014, 2015. It's above the benchmark, so we do have huge opportunities, again, in diabetes to improve. So this is a quality measure, so we do have a lot of evidence-based measures in CPRM. So you can see how we are performing in 2013, 2014, 2015. We are improving, we are making a lot of progress, and again, it's very important for us to go back and look at the EHR data and see, if this data is true. And again, this is just claims-based data. It provides one side of information here. This is another quality data that we have access to. It's again adherence to medication for CAD, and you can see our performance here. So the last data slide that I have is the patient satisfaction scores. So here we compared our 9 member organizations. The star ratings have been released from the last year. So we looked at how we are performing on an average for all the star ratings, and as at Enhance, and looked at April 2014 to March 2015, and compared it with July 2014 to June 2015. So again, this is an example of what kind of information that we have access to, and what we are planning to do in the near future is we're going to add the TCPM measures, part of the annual operation analysis, and we're going to do much more comprehensive analysis than what we have here. So I wanted to talk about a few points based upon my experience around performance improvement and data. And this is a learning that I had in the last 5 to 7 years, and I'm very passionate about performance improvement. And I wanted to point out these things as these really struck me along my journey around performance improvement. So the first point is understanding the difference between outcome measures and process measures. So Dr. Hein did talk about the outcome measures and process measures, right? So it is really important for us to understand the difference. The outcome measures are more directional, and they're often delayed. The process measures are the measures that impact the outcome measures. For an example, so if I'm looking at my weight, if that's the outcome measure, so how do I impact my weight? So I can, diet, and I can exercise, and but I need to really measure those process measures in order for me to make an impact. Usually the process measures are much harder to measure, and there needs to be a clear understanding between outcome measures and process measures. And second point is no data is going to be perfect. So whatever data that you have, every data set has its own limitations, and it has its own strengths. So it is very important for us to understand those strengths and limitations and use the data to the best possible way. A third point that I have is bad performance doesn't equate to bad quality of care. So this is one of the experiences that I had, in one of the organizations that I was working. So we were working on a project to improve the patient safety indicators, and we had like we were one of the bad performers in the state, and in fact in the country. So I was asked to lead the project, and when we were reviewing the patient safety indicators, we had 25 accidental puncture lacerations in the last 2 years, when we were reviewing the data. So with an engineering background, I was like, okay, we have 25 patient safety indicators. Are we providing really bad care? So we put a team together, and the team started looking into the charts. So we had the providers and the nursing, CDI, and coding, all of the different domains. They started reviewing the charts and identifying what are the interventions. And one of the things that we found out was, out of the 25 cases, we had 0 cases where we had clinical deviation. So that was a true experience for me, coming from an engineering background, where I was thinking that we were like really performing bad, and we were giving bad quality of care. But in fact, we had opportunities in coding and documentation. So it is very important to know that bad performance doesn't equate to bad quality of care. But this is the data that the payers and the patients are seeing, because this is what is publicly available. So it is really important for you to look into the outcome measures and dig into that and identify the true reason why you're having these outcome measures. The fourth point that I wanted to make is sharing data with frontline staff and providers. So it is very important, when you have the data, just not to keep the data with yourself. You want to share this information with your frontline staff and providers, because at the end of the day, it is them who can make a difference in the process, right? So, and also it is really helpful to engage them with showing data. So my fourth point is sharing data with frontline staff and providers for better engagement. Fifth point is celebrate small wins, especially if you're early in your performance improvement or quality improvement journey. So we often, miss or skip this piece. Sometimes we need to stop and smell the roses. It's really important to celebrate those small wins. That's how you create this performance improvement culture in your organization. So it is very important to stop and celebrate periodically. So again, those 5 points are understanding the difference between outcome measures and process measures, and no data is going to be perfect. You just need to use the data to its own strengths. And third one, bad performance doesn't equate to bad quality of care. And fourth point, sharing data with frontline staff and providers for better engagement. And my fifth point is celebrating those small wins. So to conclude, in summary, so when you start, collecting this data and analyzing, so you have seen some examples of the operation analysis, right? So what I would encourage you to do is take a look at the data that you have, do a mini operation analysis, identify how you're performing and where you have the biggest opportunities, set a team together, a cross-functional team, and start collecting the data, and plan some interventions or pilot. So this small test of change or interventions are going to be key. You don't want to implement this across all the populations. You just wanted to narrow it down and test that before you move on to the bigger population. So that's the first step, that's the plan step. So once you implement the intervention, you wanted to see whether it is successful or not. So that is where you wanted to collect the data for those process measures, identify what went well, what didn't go well, document those different observations, and then study those results. So you have the outcome measures here in the plan, and here when you're actually implementing the small test of change, you would have those process measures, which is really important to collect. And then once you have the results, you would look into those things and summarize those things. So that's the study part. So the last piece is the act. So from the results that you get here, you probably would choose one of these three options. You either adapt, which means you modify this and repeat the plan, do, study, act cycle, or adopt, where you expand these changes to other populations or other measures, or abandon, where you change the approach and repeat the plan, do, study, act cycle. So this is one of my favorite Dr. Deming's comment here. You can't manage what you don't measure. If I really wanted to improve my weight, which I should, I'm not going to be able to do that without measuring it. So it starts with data, and like you've seen the operation analysis, right? So as an example, so do the mini operation analysis in your clinic or in your organization, and then follow a structured methodology. It can be Lean, Six Sigma DMAC, A3 reports, or Plan to Study Act, doesn't matter. They all have the same core point here, and you repeat the Plan to Study Act cycle. So you not only make those improvements by doing these kind of structured methodologies, but also you would create a culture of performance improvement and quality improvement in your organization. So with that, I would let Dr. Hein conclude this presentation.
Thank you, Vineeth. So what are we asking of you for next steps? We want you to work with the QIAs to formalize a team. Now, this team does not have to be 10 people. It could be as small as 2 or 3, whatever makes sense for the work that you're involving, the size of your clinic. And I don't think anybody's going to give you a memo saying you need to have this size of team. If I were to advise you, definitely think that this work requires a clinical champion, preferably a physician who's jazzed about this in your group. They could be that leader for you. I think you need somebody who likes data, understands data, can help you do the analysis or at least the basic work. I think that a nursing or other a clinical individual would be a value add to the team, so we have a broader view of the care that's going on in your team. And if you're really forward-thinking, and how can you involve a patient in the improvement effort that you're doing? Get the perspective of the patient as you're trying to make these changes. So think about who your quality improvement team will be that will lead the improvement efforts moving forward. I think the next step is if you have access to some information, some data already, if you're doing PQRS reporting, that might be a source for you. You should have some sense for where your opportunities lie based on data. So select measures that you saw from the list that align with where you think there are opportunities in your clinic. And then as things move forward and we're generating those reports for you, to review those and report those on a regular basis. I can't underscore enough that do not avoid humble beginnings. Begin small, something that's achievable, something that's meaningful, but limited in scope, where you can learn the process, you can demonstrate improvement, and if you're able to do that, you generate this level of enthusiasm by the people that were involved with you. And I say my experience is you get it sort of in a righteous cycle. You start small, you go through a cycle, you improve that effort, people get jazzed about it. Now you've got a few other people that are jazzed about it. Your next effort is a little bit bigger, a little bit more meaningful. And in that process, every cycle you run, you pull in more people. And the one thing you don't want to do is you want to start off the gate and then fumble if your first effort. You want to make sure you've done everything you can do to make sure that first effort is successful, to demonstrate that success. Be very thoughtful about where you start small, and choose just one measure to begin with. We'll use the PDSA framework as we talked about, and take advantage of all the resources you have internally, plus enhance, plus the QIAs to assist you. I want to tell you that that story I shared about the physician, that was me 10 years ago. I was one of these docs who sat in the back of the room during the medical staff meetings at the hospital with my arms crossed, sitting next to another couple of my peers, and the whole time we would make snide comments about the wisdom being expressed by the hospital administrators in the front of the room. I was not a friend of the hospital, and I was pretty ignorant in the area, pretty ignorant about the body of work that I'm doing today. And I was in a practice with 7 other internal medicine docs. We did not have an endocrinologist, and I love taking care of diabetic patients, and I thought I was really good at it. And I had my colleagues sending patients to me to take care of their complicated diabetic patients, doing insulin pumps, and I read all the data, I followed the ADA guidelines, I was all into evidence-based care, was very sincere, very conscientious. And then the American College of Physicians, before maintenance of certification, or just as it was starting, they gave you an option. They said, look, if you want to do a performance improvement thing, it's an optional thing for your maintenance of certification, just review 50 charts of diabetic patients. I said, shoot, I can do that. So I pulled 50 charts and looked at all the measures, hemoglobin A1C, lipid profile, urine microalbumin, all the things you're supposed to do, eye screening, and I was stunned at how poorly I would get all of those according to the guidelines. And this was when we were on paper, so we didn't really have an EHR to spit this out. That experience was my journey, the beginning of my journey to end up here. A lot of lessons learned along the way. But it didn't take any sophistication for me to review my own population, to put an intervention in place, which was at the time a paper-based chart fold their file. We slipped in there. I told my nurse, please check these or review these. And I was able to improve my own performance on managing diabetic patients, a population, by using a paper-based process. And then over the years, I look back now, 10 years later, how many other initiatives I've been involved with where at the very core of what we're doing, it was exactly the same thing. Maybe it was with hundreds of providers. When I was working at the national level, thousands of providers. But the message and the method was exactly the same. That's what I meant when I said, don't overthink this. It's not rocket science. It can be done, and we're asking you to begin at this simple point. A simple measure in your clinic, learning how to use PDSA, and move the ball on that measure. And along the way, we'll get more sophisticated, more knowledgeable. We'll create that righteous cycle within your organization, and we'll help you be ready for MIPS and macro when the time comes. So, Rima, I don't know how we're doing on time. If we've got time for question and answers, we may not. But
yeah, we're good. We have about 5 minutes or so if anyone has questions for either Vineet or Dr. Hein.
Post lunch. All right. Well, thank you very much for your attention. We're certainly around all day for questions.
Thank you.
Sorry, I'm going to put the QIAs on the spot real quick since we've been talking about them a lot. Would you guys mind standing up and just waving to the audience, those of you who are in the room? So these are... we've talked about the fact that the grant is funding these resources, and so the QIAs really are there to help with a lot of this work. If you haven't already, make sure you connect with one of them or talk to me about who is your assigned QIA. They'll help you through this process of data collection and measurement, of connecting you to the right enhanced resources, of taking you through your first PDSA cycle, and so they're really a very enthusiastic and a very knowledgeable bunch, and so we're really excited to have them. We're going to take a quick break, and we will convene right about 5 till. Thanks.
Patient and family engagement in healthcare is at a crossroads. Over the last several decades, we've accumulated significant evidence about the compelling benefits